Today, we will be talking about pulmonary disorders and related emergencies. So first, let's go over a few definitions. Pulmonary means anything pertaining or related to the respiratory system. Apnea, we know when we see A at the beginning of a medical term, it means without. Apnea is without breath or no respiratory movements. Dyspnea is a shortness of breath or disordered breathing. Hyperventilation is a ventilation that exceeds the metabolic demands. Orthopnea is an inability to breathe except when you're in an upright position. This can also occur at night, and it's called nocturnal orthopnea. Sometimes a patient will tell you that they can't sleep unless they have multiple pillows propping up their head. And then respiration is a term for the process of gas exchange, whereby oxygen is gained and carbon dioxide is lost. Let's take a look at the anatomy of the airway. The rate, depth, and rhythm of breathing, they're all controlled by the central nervous system, meaning the brain and spinal cord. The upper airway is the mouth and nose empty into a common passage called the pharynx. The pharynx, usually patients will refer to that as their throat. So this is a common tube that accepts air and additionally food and liquids. From the pharynx, it separates into two passages that extend downward. The trachea, which is our air tube, is in the front and it's larger. And then our food and liquid tube is the esophagus. That's behind the trachea and that leads down to the stomach. And then finally, the larynx completes the upper airway. The lower airway consists of a lower portion of the trachea, the bronchi, bronchioles, and lungs. So here we have the lower airway, the lower part of the trachea. Then we have the bronchus, the bronchi, then a smaller portion called the bronchioles, and then finally the alveoli, these little grape-like pieces at the end. These are where the gas is exchanged. The membranes that make up the alveoli are very thin and they're also very springy. So airway obstruction needs prompt recognition and treatment because regardless of the cause, the patient will not be receiving a normal supply of oxygen, which creates almost a panicked anxiety within the patient. And so it is very important that you must remain calm. Also be aware that there are certain conditions that patients may have that diminish the ability for them to cough up something. So these conditions are myasthenia gravis, muscular dystrophy, or a previous history of stroke or cerebral vascular accident. And we'll talk about these conditions more in depth at a later date. So how do we prevent someone from swallowing? So we can use a rubber dam, and that's sort of like a membrane that kind of covers the tooth and prevents anything from going down the throat. We can pack the pharynx with oral packing. We could almost create like a pharyngeal curtain by spreading 3x3 gauze across the oral cavity especially for use on sedated patients. High-speed suction, McGill intubation forceps, which are very, very, very long forceps that can grab something, and then also ligature. So the ligature that we're talking about here is dental floss. We secure things like the clamp. So there's a metal clamp, it could be a plastic clamp that is used in conjunction with a rubber dam. When you place the clamp on the tooth, if you place it improperly, it will actually slip right off the tooth. It like pops off, and so you actually tie a piece of floss to it. So if it pops off, you can grab it very easily. So management of swallowed objects. Now we're not talking about inhaled objects, we're talking about swallowed. So the dental office is a perfect place for an airway obstruction to occur. Objects are taken in and out of the mouth, and they're often coated with blood and saliva, which makes them very slippery. Remain calm and act immediately. Most of the time, the patient will cough the object up. A foreign body, if it goes into the larynx, bronchi, lungs, or esophagus, could all be fatal if not treated properly and promptly. Do not allow the patient to sit up. Place the patient in the Trendelenburg position, head down, feet up. Using the force of gravity will help return the object to the oral cavity where it could possibly be retrieved. If it is suspected that the object has been inhaled into the airway instead of swallowed into the esophagus, turn the patient on their side and instruct them to cough forcefully. Patients should not be allowed to leave until the object is recovered. If the object cannot be located, the patient must be sent immediately for a chest x-ray and a medical consult. So signs and symptoms of an esophageal foreign body. Initially, they're coughing and gagging, but they don't have any shortness of breath. So remember, this is the food pipe. They may complain of a pain in the neck area, and it will stop if the object reaches the stomach. The pain could continue if the object punctures or is retained in the esophagus. Now, if the object is inhaled into the lower airway, it will usually enter the right main stem bronchus. So this situation is critical, but it is not life-threatening because adequate ventilation can be maintained with the left lung. However, if the object becomes impacted within the trachea, a total airway obstruction may happen. So how do we manage it? If the patient has a mild airway obstruction, and that would be defined as someone having a good airflow, they could demonstrate that good airflow by being able to forcefully cough. And you're going to encourage the patient to forcefully cough, and you do not intervene. A partial airway obstruction, which is also would be treated as a complete airway obstruction, is defined as poor airflow. So the partial airway obstruction is a weak, ineffective cough, a high-pitched crowing sound on inhalation. The nail beds and mucous membranes may become cyanotic or turn blue. And again, you'll treat it as if it's a complete airway obstruction. The complete airway obstruction, the patient is unable to speak or cough or breathe. They have acute panic. They will give the sign for choking. Their hands will go around their throat. They can become extremely blue. It will be followed by unconsciousness, cardiac arrest. So let's review the non-invasive procedures for the complete and partial airway obstruction. So adult child conscious, they are looking at you, they are aware. Ask, are you choking? You want to give them abdominal thrusts. When you thrust up. You want to mimic the movement of the diaphragm moving up to try to expel the object in their trachea up into their mouth. So you give them abdominal thrusts. If the person is expecting a baby, or if you can't get your arms around their stomach area because they're much larger than you are, you can give them chest thrusts higher up, closer to the midpoint of the chest. If it is a child that is much shorter than you, drop down on your knees so that when you're giving the thrusts upward, they really work. That's important, that you want good, solid abdominal thrusts in the upward motion. You want to repeat this until it's effective, meaning the object has become dislodged or the patient or the person becomes unconscious. So when the person becomes unconscious, you want to activate EMS. You want to position them supine and begin chest compressions. Before you ventilate them, you want to look in the mouth to see if the object has come forward into the mouth. No blind finger sweeps. You just want to, if you can see it, grab it, but no digging around because you can push the object in deeper. So those are our non-invasive procedures. There are also invasive procedures that can happen, and you won't be doing this unless you are professionally trained outside our program to do these. So a tracheotomy is a former method of choice. It's a surgical procedure used to it's a surgical procedure currently used for long-term airway management. So you may have seen patients that have been in the hospital for a long time with COVID and they have been on artificial ventilation. They will have a tracheotomy tube. It's a tube that's coming out of the front of their neck. This used to be the method of choice in an emergency situation. Currently, the method of choice is the cricothyrotomy. It's used to give an alternate airway. You have to be careful that the obstruction is above the point of incision. If the obstruction is below the incision point, you're not creating that alternative airway. The cricothyrotomy is safer and it's easier, and the incision is made into the cricothyroid membrane. The cricothyroid membrane connects the thyroid cartilage above to the cricoid cartilage below. All right, now we're going to talk about another disorder, pulmonary disorder, hyperventilation. So the definition of hyperventilation is an increase in the rate or the depth of breathing that results in a change in the blood chemistry with the normal levels of oxygen and CO2. The primary cause, the major cause of hyperventilation is acute anxiety. It's most often seen in patients who attempt to hide their anxiety. It's rare in children and older patients. Then the recognition and management of anxiety can actually prevent it. Additionally, there are drugs and central nervous system disorders, and pain may also precipitate a hyperventilation. So signs and symptoms of hyperventilation, there's nervousness, the increased rate and depth of breathing. So their respirations will be at about 25 to 30 per minute. They'll have a tightness and kind of a suffocation feeling in their chest. They may become lightheaded, dizzy, giddy, kind of be like a silly excited, and a tingling and numbness in their extremities, meaning in their hands and feet. The pathophysiology. So what is happening is anxiety increases the respiration rate, and the level of CO2 in the blood is what automatically triggers the breathing reflex in our brain, and it stimulates respiration. Hyperventilation results that you're blowing off too much CO2, and this lack of CO2, carbon dioxide, means the patient now has to consciously work to inhale and exhale. And usually exhalation, things like that, is very passive. You don't even notice you're doing it. So when you have to consciously work to inhale and exhale, it makes people very nervous. So it also results in a vasoconstriction in the blood vessels in our brain. When you vasoconstrict the blood vessels in our brain, this causes an ischemia, which accounts for the lightheadedness. Rarely, this ischemia can result in unconsciousness. So the hyperventilation cycle is a person is anxious. They start to hyperventilate. They have a difficulty breathing, which creates, guess what? More anxiety, increased hyperventilation. So your role is to intervene and break that cycle. So like everything else, remain calm. With you remaining calm, that also helps to reduce the patient anxiety. Stop treatment, remove objects from the mouth. Additionally, you should remove objects such as a syringe from the patient's line of vision. Place the patient in an upright position and try to calm them and slow their breathing. To correct the oxygen and carbon dioxide balance or imbalance by having the patient rebreathe exhaled air by breathing into their own cupped hands. Oxygen is contraindicated as it would further decrease the levels of CO2 and remove the remaining stimulus for breathing. In cases of severe anxiety, an anti-anxiety drug such as a benzodiazepine like Valium or Ativan may be given pre-treatment. Asthma. Asthma is a chronic, meaning long-term, not acute, which is short-term. It's a chronic respiratory disorder that produces periodic or occasional reversible airway obstruction. It's caused by bronchospasms, which means the bronchioles go into a spasm. And when they spasm, if you've ever had a spasm of your back, it kind of contracts. So these bronchospasms cause constriction, hypersecretion of bronchial mucus, and bronchial wall edema, a thickening. The classic signs of asthma are dyspnea, disordered breathing, wheezing, which is like a whistling, and a cough. So there are different types of asthma. So we have an extrinsic asthma, which is also known as allergic asthma, seen most often in children and young adults, more commonly in males. Most patients are aware of the allergens that trigger their attacks. So an acute episode is usually caused by an exposure to an allergic substance such as dust or pollen. The bronchospasm develops within minutes after exposure to the allergen. So allergen is the antigen. So that kind of sounds like the same. So this allergic reaction is called a type A hypersensitivity reaction, in which IgE antibodies, so the antibodies are what's made by our body. So our body produces the antibodies in response to the allergen or the antigen. Most patients are aware of what triggers it, and you must take care to avoid exposing them to the substances which could trigger attacks. Penicillin and aspirin, and to a lesser extent, NSAIDs, which are non-steroidal anti-inflammatory drugs like ibuprofen, are drugs the most likely to cause a person with extrinsic asthma to have an attack. Be also aware of dyes and preservatives that are used in dentistry, like fluoride or disclosing agents. About 50% of children will outgrow this type, and the patient is usually symptom-free between attacks, and it also responds well to medication. Intrinsic asthma, also known as non-allergic asthma or infectious asthma, you're not going to catch this kind of asthma. It's not infectious to you, but a lot of times an infection causes it. So it usually develops in adults, primarily females, after the age of 35. The attacks are usually brought on by a respiratory infection or inhalants, cold air. And it's not necessarily like if you've ever had a respiratory infection and you get the cold into your lungs, it's like, right, and you really can start coughing. What it actually is cold air is dry air, and anything that is dry actually can precipitate this attack, because for the most part, like, we're sort of a bag, our bodies are just a bag of hot juice, right? So we're 98.6, we're really juicy with a lot of blood and mucus, saliva, everything is wet and hot within us. So when you introduce something cold and most specifically dry inside, sometimes it can create the bronchioles to go into a spasm. Also, exercise and stress can bring on an intrinsic asthma attack. So the patient usually will have a chronic, a long-term cough with mucus production. So they're kind of like hacking up a lot of phlegm in between attacks. They don't have any history of allergy. The attacks are usually more severe and they have a poorer prognosis. There are some common factors that are the same between extrinsic and intrinsic asthma. And those common factors are lots of like mucus. They also have like an abnormal cough reflex, and their airway smooth muscle, those bronchioles, have an increased capacity to contract due to a response to different agents. There's also a mixed type, which is a mixture of extrinsic and intrinsic asthma. It is difficult to treat, and the attacks are more likely to be brought on by an infection. Status asthmaticus. Now, this is the most severe form, which does not respond to usual drug therapy. It can be life-threatening. The patient is usually hospitalized. It can occur with any type of asthma. So a lot of what we talk about with asthma, we're talking about the bronchioles, the walls becoming thicker, and actually the spasming. So it's like the lumen, which is sort of like the internal diameter, how much airflow can pass through, is getting smaller and smaller and smaller. The epinephrine is a potent bronchodilator. So what that means is it opens up those bronchioles. And once those bronchioles are open way up, more air can pass through. So epinephrine is the drug of choice for status asthmaticus. So dental precautions, we have allergens. So you want to question the patient very carefully regarding allergies and what products or drugs could bring on an attack. Stress, anxiety, fear, pain could bring on an attack. Some dialogue questions for the patient, lots of questions. Like, what type of asthma? What age? How often? When was your last attack? What brings on the attack? Describe an attack. Have you ever been hospitalized for attack? Have you ever had an attack in a dental setting? Do you take any medications? Additionally, patients that are usually more poorly controlled maybe take an inhaled steroid every day. If they are taking an inhaled steroid, it can create sort of a localized immunosuppressed situation in the back of the throat. It puts these patients at high risk of developing candidiasis or yeast infection. So you want to tell those patients to rinse their mouth with water after they use their inhaled steroid. You may additionally want to prescribe a home fluoride to reduce dental caries because asthma medications can be very drying. Some drugs to avoid: aspirin, NSAIDs, penicillin, codeine, all have a high rate of allergic responses in asthmatics. If the patient is taking an inhaled theophylline, which is a bronchodilator used in more severe forms of asthma, you don't want to combine that with erythromycin. You don't want to give asthmatics local anesthetics which contain sulfites. Sulfites are preservatives, and in local anesthetics that have a vasoconstrictor in the solution, they need a preservative to preserve the vasoconstrictor. So sulfites, you may have also heard of them. Sometimes people say they're allergic to salad bars. Salad bars, they spray sulfites onto the salad bar to keep everything looking fresh, to preserve it. So these sulfites actually can precipitate or cause an asthma attack. And then we also want to modify treatment, stress reduction protocol, and anticipate an attack. Have those inhalers right on the counter. So here are ASA classifications. So ASA2, infrequent attacks, easily managed, no prior hospitalizations. ASA3, frequent attacks, exercise-induced asthma, the anxious patient, prior history of emergency care or hospitalization. And then ASA4, chronic signs and symptoms of asthma, even at rest, with no stress, nothing, no exertion. ASA4. They'll need a medical consult and you'll need to delay treatment. So a mild attack will include wheezing, and wheezing is that sort of whistling, and that's during expiration or also known as exhalation. Coughing, feeling of thickness in the chest. The patient is going to want to sit up to get more air in. They may become anxious and their heart rate and blood pressure will increase. If they have a severe attack, it's intense dyspnea and orthopnea. The patient will they'll have like their nose up to the ceiling, sniffing, trying to get air in, okay? And they're going to be very anxious. They may become cyanotic. The face may look very red, and they may become mentally confused. And the status asthmaticus is this episode will continue despite drug therapy, and this requires hospitalization. So this is a lung, normal lung. We have the tube for our airway, our trachea. You can see bands of muscle that are wrapped around. Here's the air sacs or alveoli, and here's a cross section of the inside of the airway, and this is normal. Lots of air can get through here. So what is going on during an asthma attack? So we have chemicals that are released. They're known as the chemical mediators of inflammation. These chemical mediators of inflammation include things like histamines, leukotrienes, prostaglandins, and they are released as a result of an allergic reaction or other primary provoking factor, stressors sometimes even. These chemicals produce distinct changes which result in the classic signs and symptoms of an asthmatic attack. So we end up with bronchospasm, which is the constriction of the bronchioles, and therefore like now the airway passages are smaller and you have respiratory difficulty. The bronchial walls themselves become thicker due to the inflammation from these chemical mediators of inflammation. And again, it makes the airway smaller. You also will begin to secrete mucus. If you've ever been allergic to something, you will notice like your nose is running, everything is running, you're dripping with mucus. Well, that's also being secreted in your lungs. And because the airway is much smaller in the bronchioles, you're unable to cough up the mucus in your lungs. So it leads to getting these thick mucus plugs. And so we can see here the cross section. So now this is during an asthma attack. So the spasm happens in the airway here. The lumen gets smaller. Now you have the edema that's happening. The walls are becoming thicker. And now we also have spasm, edema, and now mucus as well. So you can see how tiny the airflow can be through this bronchiole. So the three factors, the spasm, the edema, and the mucus, lead to a decrease in the size of the lumen, which is the opening. So when you decrease the size of the lumen, it means you've narrowed the bronchioles and you have a partial airway obstruction and also increased airway resistance. So it's harder to bring the air in and then exhale it out. So as a result, your muscles of expiration, which are normally passive, don't even think about it, it doesn't even occur to you that you're doing it, have to work to expel air. And this airway obstruction leads to a decrease in the blood levels of oxygen, which changes our blood chemistry and the pH of our blood. So an untreated asthma attack can lead to a life-threatening situation because of changes in the blood chemistry and the blood pH. So how do we manage it? Stop the dental treatment. Position the patient, whichever is most comfortable, it's usually upright. Give them their bronchodilator by inhalation. It's preferable to use their inhaler, which should be available from the beginning of the appointment. Don't have them keep spraying it into their mouth, because if you administer more than the maximal dose, sometimes that could have an adverse effect on the heart, and blood pressure can cause them both to go up. You could administer oxygen. You can give an intramuscular injection of epinephrine. Again, bronchodilation. Open everything up. Open up those bronchioles. Get that lumen really wide. Summon medical assistance if the first steps 3 through 5 have little or no effect. Permit the patient to recover fully before dismissal.